Okay, what am I doing now? Oh yeah. So we had a lot to do this week, a lot of reading, a lot of crunching, but here we are. So everyone wants to know.
Not a lot of sleeping. No,
No, not a
not
lot.
zero sleep.
So we're living in a world of risk right now, okay? And I think we're being distracted by a lot of media nonsense, our own personal, leanings and biases. But if asked to work on this at the, if I were to step into the shoes of someone at the CDC, at NIH or whatever, this is what I would do. This is what I would stress. This is what I would take to Congress and the White House and urge them to do as soon as possible. And again, this reflects my knowledge, my experience, and both as a, clinically as a physician, but also in the worlds that I have been privileged to work in, such as population health and clinical genomics and evidence-based medicine. So here it is. We live in a world of risk, and the risk has been presented to us by this pandemic. So one of one of five things, the first of five things that we need to really address is we need to know the prevalence of this disease. We need to know how many asymptomatic carriers there are, how long they asymptomatically carry for, how many people are seropositive, have converted from illness into protective neutralizing antibodies. All of those numbers are very important. If seroprevalence, which is also a proxy for herd immunity, is 3% or 5%, or in some places high as 20%, then we approach those areas differently. Okay, it's not a one size fit all. You can't shut down a county or a state because each of the, you shouldn't, I should say, going forward, we shouldn't do that. We should have granular level data that allows us to understand the risk levels in not broad geographies, but in specific areas because of specific reasons and specific threats. So we need to address the prevalence, assess the prevalence, and that means we have to provide testing on demand. Love it to be free because, I think in the wealthiest country in the world, we should provide free testing. In Germany, you can buy swab tests for $18. I don't know if they're providing them free because they're not in the same position that we're in right now. We have the highest number of cases. We have the highest number of deaths. We need to get really, really serious on getting through this. Okay, so I'd love it to be free, and because the reason I'm saying this is because we talked about social determinants of health, like 4 or 5 weeks ago, John, about when we first learned that the urban Black Hispanic communities are disproportionately being affected because of their living conditions, because of lack of access to healthcare, all those reasons. We need to test the bum on the street because we need to know that he's, not going to end up with it and spread it, by inadvertently sitting on a park bench that your aunt is going to come and sit on tomorrow, and then take that home and infect her husband. And it goes on and on like that. These are the nightmares that epidemiologists suffer, okay? We need to test everyone. We've got everyone who wants a test needs to get a test in reality, okay? That is important. So serial detection and antibody testing on demand, that means people with a very high risk job, like people in healthcare or people that work in, stores where they're providing services to hundreds of people a day. They need to be tested similar to what was proposed in New York, which is if you work in a nursing home, you need to be tested twice a week. Because if you bring a virus into a nursing home, you're going to kill someone. Their infection fatality rate isn't hovering around 1.5%. It's at around 12 to 14%. Okay, you're going to kill someone. So we need to have serial detection tests for those that work in high risk scenarios, and then antibody testing on demand. If you say, look, I recovered from a wicked bad illness, and I want to know and contribute to the data set of seroprevalence, I want to know if I have the antibodies. So that's that top line. Okay, so rigorous contact tracing. Again, let's get back down to the bubble and the granular data. You know, I'm soon to include John into my bubble. I'm going to invite John over, and we're going to have burgers, okay, or we're going to have whatever he likes to eat. Ideally, I invite him over after he stopped at Rite Aid and got a swab test, and it came back negative, right? But if it came back positive, the swab test, John's not coming over, all right? And John needs to talk to somebody about the last 25 days of his life. And after that, that person needs to talk to those people that John came in contact with and find out if any of them are sick or were sick. And then we need to work on how to quarantine, humanely quarantine, either at home or somehow, only those people who are positive. There are lots of problems with this second line, all right? But I think the most important problem that myself and my colleagues in the scientific community, biomedical community have to tackle is the sensitivity of the tests. They've got to be highly sensitive. We can't deal with false negatives anymore. We have screwed this up in the first 6 weeks. We can't, just got to lock that down. 95% sensitivity or above only, and only those people who are doing tests with that kind of sensitivity should be allowed to do those tests. All right, next, healthcare access. We need a temporary COVID treatment for all. If you're sick with COVID, do not be scared to come to the hospital and get treated, because you'll get a $40,000 or $400,000 bill somehow or the other. If we're going to eliminate it from our communities, especially communities that have huge levels of wealth disparity and health access disparity, we cannot allow people to be scared and live scared without getting treated. And then this is something we covered again last week, which is you've returned to business. You are doing great, and you are one of these cases on above, on one of these above that we just discussed. You work at Best Buy, and there's a huge demand of people coming in and out. 200, 300 people are shopping at your store, and you're keeping yourself safe and you're doing all the regular stuff. But week 3, you start feeling sick, and then you get tested and you're positive, and you have to be quarantined. At the earning potential there, these stores, large stores, I mean, family businesses and others, we can talk about that, but they need to be able to provide paid convalescence for 6 weeks. You need to take these people out of the workforce, because all they're going to do is continue to infect others. And they need to be able to go home and get better, and not infect any more people and not worry about the bills. All right. Data and analytics, my world. Give me the data, give me all of the data, and give me nothing but the data. We need to be able to have the data to assess daily trends, granular level, at the level of a zip code or a neighborhood, to be able to control, track, and trace, and eliminate threat before it spreads to the part of the geography where you need to shut down an entire geography, which is stupid because it affects too many lives. And next week or the week after that, we're going to have Dr. JJ Racimus, who is an MD PhD psychiatrist, toxicologist, join us and talk about diseases of despair, because they're already growing, and locking down people or locking down geographies for more time is just going to foster their growth. And we can avoid that if you can give people like me the opportunity to develop these strategies and implement them. So recommended strategy is people should start to listen, right? We need to have some way to get Dr. Rachel Levine and all of her colleagues and peers across the all the states access to this data so they can make the best decisions on a day-to-day basis. And that will, data is power. And then lastly, important, not as important as the other 5, but important is tracking of strains that are inbound to our country. So like we said earlier in the town hall, you could have gotten it, the New York strain recovered, you've got antibodies against the New York strain, and then a new antigenic strain arrives in New York City from wherever, from Spain, Italy, you name it. And then we're back to square one to some extent. So airport testing, inbound immigration, customs, all of that stuff in a humane way. So there we go.